before we move on, I just want to sort of get a benchmark. Where do we stand right now in terms of levels of awareness of this problem, of AD, among the community, I guess it's patients, among physicians, specialty pharmacies? Are they aware at all that this is coming their way? Is there's a train coming down the track? And what about health plans? You've talked about health plans, but what else? Where's the level of awareness here with all these?
I'd say it's pretty low, generally speaking.
It's low.
Unless you have, except for those people who are specifically watching the pipeline and are managing budgets and managing formularies. But generally, no. I think, again, there's a misperception that this is eczema. I think some people think that this is cosmetic. Right?
I think
so
you're
there's
spot on there. Yeah. I think, eczema has been around. It's, you treat it with over-the-counter steroid.
And they're generics.
A payer thinking about atopic dermatitis, there's not the awareness that really this is this large issue.
And payers really have a data problem here. It's like we don't know the whole sphere of patients who have all of this. We can't find it all in claims. And one of the things that would really help here would be to start thinking about, is there an algorithm you can use on claims to find the most severe patients as sort of a starting point? Because those are patients who probably have a proper coded diagnosis and who are receiving some sort of therapy that we're paying for. They're not just using, a moisturizing cream. They're on, an expensive fluoridated topical steroid of some sort, and they're getting it in gallon drums. And so at some point, we should be able to at least figure out who the severe population is. And right now, nobody's tracking that, but it's doable. But if you said, well, I want to figure out the entire atopic dermatitis group and then segment them into this or that, you're not going to find all of those folks, because most of them we don't have a claim for them.
And there will be some self-selection here. And also, yes, Cheryl's earlier point is we're not talking about 30 million people. There will be some self-selection because these are not oral once-a-day tablets, and they're expensive. They're going to be in specialty tiers for the most part. Okay. So there will be some self-selection.
Right. We're going to get to all of these medications, but if I take a look at your body language, at least early on, it was like, be careful. That light at the end of the tunnel is the headlight of an oncoming train, and that's expensive.
We tend to overreact to things that are coming, and it settles out. But we have to have some comfort level that these drugs are being used appropriately.
Okay, well, let's move on just a little bit and shift gears. Let's talk about a little science. What's known about the causes, the pathophysiology of AD, and how has this evolved over time?
Sure. So there's actually been a big shift right now in the dogma. There's been this existential debate about whether or not atopic dermatitis is a disease of skin barrier, where the skin barrier is impaired, and as a result, that allows junk from the outside world in, and eventually
That's a technical
inflammation.
term, junk?
That's my...
That's your...
versus this sort of idea that inflammation may be at the heart of it, and that there's something wrong with the immune system as the underlying trigger, and then that causes secondarily this dry skin phenomenon and the rash.
Okay.
And for the past decade, we've seen a ton of development with over-the-counter agents and some of these prescription emollient devices that have really focused on the barrier story. But now we're starting to see a whole lot of development in the inflammatory side of things, where we're seeing that you can really get this targeted treatment of inflammation and get outstanding results.
Okay, so let's turn to these, because he's already beginning to shiver on the side over there.
Well, that's what gets back to the indirect versus direct. I mean, that's what we want. We want to have a discussion around inflammation.
We're going to get there, yeah.
Those kind of things, not how well you can.
Cheryl, bring us up to speed. Now these emerging therapies, he's afraid of them from a cost perspective, but in fact they might be effective, which would make it even worse, because you'd have to pay for them. What have we got? What are some of the targets being investigated?
Well, there's some close target agents that we're monitoring the pipeline. Pfizer has crisaborole. This is an acquisition.
God, I'm glad you can pronounce that.
An acquisition through the Anacor. This is going to be a topical PDE4. So we'll see this as a small molecule and probably be priced as that small molecule. This is an ointment.
It's still
topical.
a concern in a generic and over-the-counter space. It would still be a concern.
Okay. And tell me about the data. Does it work?
Well, the data looks good initially. The study came out and it's used twice daily. The study was for 28 days and the data was reviewed on day 29. So what we would like to see is a little bit more on that data to show some efficacy.
Is this phase 3 data? What kind of data?
It is phase 3 data. So the FDA will review that and we'll see what happens with that agent. But we're pretty excited about dupilumab. So that's a Sanofi Regeneron. This is going to be a biologic. So this is really something that's going to come in and help to really get to the cause of this. So as Dr. Silverberg said, now with the newer drugs, we're looking at really going into the immune system and targeting that therapy. This is going to work on IL-4 and 13. So very excited about the studies that are coming out there and the true markers that we're seeing some really, when you look at what the body surface area, what the improvement there, the ESAI scores are better. So very exciting.
Okay.
One of the things that we're a little bit concerned with is the loading dose and injection on this. So whereas the topical agents right now are used in mild to moderate, even the crisaborole is going to use mild to moderate, and that's age 2 years old and up. Dupilumab is going to be adults and injectable. So this is something new for this patient population. So a lot of education around this.
And so we have data, and as I understand it, it's Solo 1, Solo 2?
Solo 1,
Those
Solo
are the
2.
two studies?
Yes, Solo 1, Solo 2. Efficacy was shown in both, in those key measures that we're looking for. So I think those are going to be some of the things that will speak to the health plans.
But this goes to what you pointed out too. By the time you're ratcheting up to some of these newer therapies, there's a lot more patient investment because it's an injection. It's not just
It is. Again, there's a lot of need for patient education. The out-of-pocket financially to the member or patient is a lot higher. So they have to themselves have to decide if it's worth it to spend.
So it's a
this money to get
self-selection thing,
Yeah,
not
but
necessarily for money, but in fact for
Exactly.
inconvenience and pain.
But
and
the nice thing
injections.
about, from what I understand with these studies, is it's on top of standard of care. So it's on top of
Right.
the steroids and
Okay.
TCIs and other things. So it's not as monotherapy where we're really struggling to see where does this fit versus an inexpensive.
It's being studied as
topical.
both. It's being studied as both, so we'll see if monotherapy, but one of the ways that it could be used is in these times of flare, right, where we're trying to control the patients.
Which, when you start talking about compliance programs and what specialty pharmacies do and things that we will talk about later, that's an issue, because understanding that, because if you talk about psoriasis and other things, we track adherence and persistence, and that if that's not applicable here, then we're going to need to understand it.
But again, that's almost up. It's on you to work out the model, right, or not?
Well, it
the
falls
financial
on us.
model.
It
anyway.
falls on us, unfortunately,
does.
but it shouldn't be that way. But it falls on us. Yeah.
It's that old superhero.